Hello everyone, welcome back to another video. So in today's video, we'll talk about contraception, which is one of the MCC objective. That means it is relevant for your QE1 and NAC OSCE. For NAC OSCE, they might give you a station where they will ask you to counsel a patient on contraception, different methods that she want to explore on contraception. So you need to teach her. In QE1, there could be a situation where you gotta do emergency contraception for a patient, or let's say she has some contraindications, and then you gotta recommend or select the most appropriate contraceptive method for her. So, in terms of, let's say, objectives, they want you to know hormonal, non-hormonal method, natural methods, permanent contraception in male and female, and then the one of the most important one is emergency contraception. General sexual history, risk factors for complication, result of an appropriate physical examination that you'll do, critical clinical investigations like pap smear, cultures, STI screening, and pregnancy tests when appropriate, effective initial management plan, prevention plan, and risk of failures, potential complications, contraindications of each method, protection against STI and drug interaction associated with each method, and discuss emergency contraception as a backup when needed. So let's open Toronto Notes now, and then we'll study about. So this contraception topic, this is in two different chapters. One is a family medicine chapter, and the other one is gynecology. So this is the family medicine portion. Emergency contraception is one of the objective and MCC objectives, so make sure you know it better. So emergency contraception is there are two different kinds. One is the intrauterine devices. The other one is the oral ones. Oral one is Plan B. Usually two doses are taken, which are 12 hours apart. And the other one is post-coital copper IUD, intrauterine devices insertion. So these are two different options. And then the other one is a hormonal one, IUD, which is effective within 72 hours of unprotected intercourse. So, copper IUD and hormonal emergency contraception. Hormonal emergency, you have to take it within 72 hours of unprotected intercourse, and you have to take two doses 12 hours apart, which reduces chance of pregnancy by 85%. Most effective if taken within 24 hours. The sooner it is taken, the better it is. The other one is the copper IUD inserted within 5 days of unprotected intercourse are significantly more effective than hormonal emergency contraception. So two different types. One is copper IUD, other one is hormonal contraception. Hormonal is best if taken within 72 hours or 24 hours, and copper IUD can work within 5 days of unprotected intercourse. Pregnancy test should be performed if no menstrual bleeding within 21 days of either treatment. That means, let's say you've given contraception to a patient, and then even after 21 days, she's not having her menstrual period. So you gotta test her for beta HCG or urine pregnancy test to make sure she's not still pregnant. Advanced provision of hormonal contraception, emergency contraception increases the use of emergency contraception without decreasing the use of regular contraception. So, pharmacists across Canada can dispense Plan B, which is an emergency contraception. So the patients do not need to come to a doctor to get Plan B. So let's say in NAC OSCE, if you're counseling a patient, you need to tell them that in case this is the contraception. Let's say you're counseling a patient on oral birth control pills, and you're telling the patient to be compliant on that. In case they have an unprotected intercourse, they've missed their dosage, so they can take emergency contraception. In that case, they don't need to come to you. They can rather go to a pharmacist and get it dispensed from there as Plan B, and then they can take it right away, two doses 12 hours apart. So that's the family medicine part of contraception. Now we'll move to gynecology part, which is GY15 23. Okay, so we are almost there. So for contraception, this is a very important topic, I would say. Even clinically now in residency, I realize that this is one of those topics which we actually encounter in clinics, and patients want to know more about that. And as healthcare providers, we have to counsel them. So honestly speaking, everything that we learned through the exams like BEAT, NAC OSCE, or QE1, this is practically very relevant. And that's what I realized when I got in residency. So if, let's say, you're studying about anything, if you start studying in a way that it's going to help you in future, you'll surely enjoy it more, right? So let's talk about counseling the adolescents about contraception, the box on the right side. More than 90% of adults in pregnancy are unintended, and 50% of all pregnancy occur within the first 6 months of initiating sexual activity. In addition, 85% of sexually active women become pregnant within 1 year if no contraception is used. And even some of the least effective contraception method markedly decrease the risk of pregnancy. So that's just the percentage of how common unintended pregnancies are. So classification of contraceptive method, they are physiological method, and then they have given you the percentage effectiveness of each. So nothing very you don't have to learn them, but just like know which method is 99.9% effective, that is vasectomy or tubal ligation. These are the most effective ones. Or postcoital IUD within 7 days is also 99.9% effective. Ella is another one, which is an emergency contraception, which is also very effective. Plan B, all the emergency ones are very 98 to 99% effective. Whereas IUDs, copper IUD, or let's say the hormonal IUD, which is Mirena or Nexplanon, are also very. Nexplanon is a subdermal device, which is all, these are all hormonal, but they're very, very effective. Um, Barrier methods or physiological methods are not very effective in general. Barrier methods, female condoms or diaphragm, are also effective, but not as effective as hormonal IUDs or copper IUDs. Okay, now hormonal methods. Combined oral contraceptive pills, which are the most common ones. Every other girl is on OCP, but most commonly these are used for heavy menstrual bleeding. That's what I've seen. Or they can be used for contraception as well, but IUD is another most common one after oral birth control pills. So now talking about what Toronto note says about it is daily pills with a 4 to 7 day placebo or pill-free break to allow for menstruation. So people with, let's say, who are going for NAC OSCE, or people who are new to Canada, let me tell you. So there is a blister pack of COCPs, and there is, let's see if we can find a picture on Google just so I can show you guys how that is. Some people might have seen that, but usually let's say if you're counseling a patient, you got to know more on. Okay, so that's how a pill, a COCP pill looks like. So these are, let's say, the brown pills are the sugar pills or placebo pills, and the white pills are the hormonal pills. So if you keep the hormonal, you continue taking the hormonal pills, and then when you're taking those brown pills or sugar pills, which are commonly called as sugar pills in Canada, so when patients are taking those, they usually get breakthrough bleeding or withdrawal bleeding. That means there is no hormone; they're not taking any more hormone. So there would be some withdrawal bleeding to let the endometrium shed those extra lining in there, and that would help them uh, get rid of the extra endometrial lining, and then they will get back on their hormonal therapies. Okay, so that's how it looks like. Now, going back to combined oral contraceptive pills are the ones that I just showed you. Daily pills with 4 to 7 placebo, pill-free break to allow for menstruation. Estrogen suppresses FSH and follicular development. Progesterone prevent LH surge, suppresses ovulation, thickens cervical mucosa, decreases tubal motility, and desudilizes endometrium. So this is the physiological effect of estrogen and progesterone, like what happens when you take a combination of both. So estrogen basically inhibits a follicle stimulating hormone or follicular development, whereas progesterone mostly acts on your cervical mucosa, on your endometrial lining of your uterus, on your tubes, on ovulation, and prevents the LH surge. So everything except for FSH is controlled with progesterone. Most contain low dose ethinyl estradiol, 20 to 35 picogram, plus progestin, norethindrone or norgestrel, levonorgestrel, desogestrel, or norgestimate or drospirenone. So these are different kinds of progesterone. So that's a combination. That means low dose of estrogen and more dose of progesterone. Failure rate is at 0.3 to 8% depending on the compliance. Monophasic formulations have the same amount of progesterone throughout cycle, while triphasic formulations have varying amount of progesterone throughout the cycle. So there are further two types of COCPs, monophasic or triphasic. So monophasic have same amount of progesterone, and triphasic have fluctuating amount of progesterone throughout the cycle. Now coming to transdermal ortho evra. So, or transdermal ones, I've not really seen them a lot, but the most important thing for NAC OSCE that you really need to know about this, even for clinical practice, that what I found is patients want to know the duration, right? Let's say how long is gonna transdermal patch last, or how long is gonna IUD last. So that's really relevant, and how long is gonna ring work for them, right? So that's important. And then what are the complication risk associated with them? So transdermal patch that are changed every week for 3 consecutive weeks, then left off for a week to allow for menstruation. So they are put in there for 3 consecutive weeks, and then they're left off for a week to allow for breakthrough bleeding. Continuous release of 6 milligram norgestromin or point 60 milligram ethinyl estradiol, which is estrogen to bloodstream, applied to lower abdomen, back, upper back, buttock, not breast. Why not on breast? Because it has estrogen, and which can because estrogen is related with breast cancer, so not on breast, because if they are absorbed through the breast, there's a high risk of cancer, breast cancer. As effective as OCPs in preventing pregnancies, more than 99% with perfect use. Maybe less effective in women more than 90 kgs. So obesity equals high adipose tissues. High adipose tissues means low absorption. So that's the reason. So most relevant thing about this is the duration, which is 3 weeks on, 1 week off, and not on breast. As effective as OCP in preventing pregnancy. That means more than 99% of the times. So that's transdermal. Then come contraceptive rings. Thin, flexible plastic ring that is inserted into vagina by patient and left there for 3 weeks, and then removed for a week to allow for menstruation. Release estrogen, estradiol. As effective as OCP in preventing pregnancy, 98%. Side effects is vaginal infection, irritation, vaginal discharge, associated with less breakthrough bleeding than other methods. So this is more localized, but it can give vaginal infection. Why? Because it is inserted down there. So but it still has what do we call hormones, so it is one of the hormonal option as well. So contraceptive vaginal rings, infection, and 3 weeks on, 1 week off for breakthrough bleeding. Starting hormonal contraception, thorough history, blood pressure. So let's say a patient is there, she wants to know about contraception. So what I usually, my approach in that is, I take history first, and in that history, my questions are relevant to cardiac history. My questions are relevant to migraines, any history of breast cancer, any history of bleeding disorders, because hormones are associated with increased risk of all these things. So, thorough history, blood pressure measurement, because blood pressure is ultimately related to cardiac conditions as well. Post pandemic SOGC guidelines do not require blood pressure readings anymore to allow for virtual appointments. So that's a virtual thing, something new that is added after pandemic. Pelvic exam not required, as STI screening can be done by urine. Pap smear screening does not start until more than 25. So there's no screening or pap smears done. So there's no requirement of these things before we start the patients on contraception. But the only thing that you really need to test the patient on is that she's not pregnant, and that's about it. And then screening for all those cardiac conditions and all that we discussed before. Can start at any time during cycle, but ideally within 5 days of her last menstrual cycle. So let's say if patient is coming in, what's the best time? She can start it right away. Okay, then it will get with the flow. But the best time to start contraception is 5 days after her LMP. Follow-up visit 3 months after hormonal contraception prescribed. Let's say you've prescribed it for 3 months, and now after 3 months they need to follow up on how is it working, if there's any side effects, if there's concern, if her menstrual cycle has got back to regular, if they're bleeding a lot or no. All those kind of questions on the follow-up. Generally recommended to use backup contraception for 7 days, particularly if initiated more than 5 days from her LMP. So recommended, because right away, let's say if a patient has had her menstrual cycle, and right after finishing her menstrual cycle she started on contraception, then there's no room that she can become pregnant if she was right away started on contraception. But still we keep a backup contraception. We advise backup contraception for a week if she was started, let's say in middle of her cycle. Let's say she was 2 weeks away from her cycle and she was started on contraception, then we recommend to have a backup contraception within for 7 days at least. Now, talking about combined estrogen and progesterone contraception methods. So, what are the advantages? Advantages, they are highly effective, they're reversible. Cycle regulations. I've seen patients who says, they say that their cycle have been regulated, they're not heavily bleeding. So, it decreases dysmenorrhea or heavy menstrual bleeding. I've even seen people, I've even seen like commonly practice that fibroid patients are being treated with oral contraceptive pills because it decreases the heavy menstrual cycle that they usually get. So, heavy menstrual bleeding, less anemia, decreased benign breast disease or ovarian cyst development, decreased risk of ovarian endometrial cancer. So, hormones decreases the risk of ovarian and endometrial cancer. Increased cervical mucus, which may lower risk of STI, decreased PMS symptoms, less acne, osteoporosis protection, patient controlled, so they can stop using it and they can plan their pregnancy accordingly. So these are the advantages. So good, very good table for NAC OSCE if you're going through that. So make sure you review this table and you'll have these benefits on the tip to let the patient know on that. What are the side effects? Side effects are estrogen related side effects like nausea, breast changes like tenderness, enlargement, fluid retention, bloating, edema. Weight gain is a rare one, but it is a possibility. Migraine, headaches, um, thromboembolic events, liver adenoma, or breakthrough bleeding, low estradiol levels. Progesterone related are amenorrhea, breakthrough bleeding, headaches, breast tenderness, increased appetite, decreased libido, mood changes, hypertension, acne, oily skin, hirsutism. Androgenic side effects may be minimalized by prescribing formulations containing desogestrel, norgestimate, drospirenone, or cyproterone. So these are different formulations in which there is more androgenic, less androgenic side effects. So these are the ones. But in general, I have seen like patients using the new formulations which I've just mentioned here. They're really good for acne treatment and for controlling their cycles as well. So that's one of the thing that acne or oily skin. So that can be even treated with these androgenic side effects minimizing prescriptions. What are the contraindications? Absolute contraindications or relative contraindications? Absolute one are 4-week postpartum breastfeeding women or less than 21 days postpartum, not breastfeeding. So if let's say a patient is breastfeeding, we recommend that they start contraception on at 6 weeks. If they're, let's say, exclusively breastfeeding, they can start oral contraceptive pills from 6 weeks to 3 months, and they are preferred to be on progesterone only pills. Or if, let's say, patient had major surgery with prolonged immobilization, known suspected pregnancy, undiagnosed abnormal vaginal bleeding, prior thromboembolic like bleeding disorders, cerebrovascular, coronary artery disease. So this list of contraindications is very important clinically and for NAC OSCE. Why? Because you have to rule out if the patient is having, either one of the condition, then they might not get OCPs. Rather, they may have, like, let's say, an IUD, copper IUD, and all that. Estrogen dependent tumors like breast and uterus tumor, impaired liver function associated with acute liver disease, congenital hypertriglyceridemia is another one. Smoker, more than 35 years and smoker. Migraines with focal neurological symptom excluding aura or uncontrolled hypertension. So you see the most common ones: smoker in more than 35 years of her age, uncontrolled hypertension, migraines, liver disease, estrogen dependent tumors like breast and uterus tumor, cerebrovascular disease, coronary artery disease, bleeding disorders, vaginal bleeding, suspected pregnancy, major surgeries and immobilizations, or postpartum, 4-week postpartum. So do not use OCPs. Relative ones are migraines, non-focal with aura less than 1 hour. So there is a nitty-gritty here, and that's really important for QE1. For migraines with focal neurological symptom excluding aura is an absolute contraindication, whereas migraine with non-focal with aura less than 1 hour is a relative contraindication. So this can be tested on QE1 as well. So there are two different types of migraine that they are referring to. Focal neurological is a complete contraindication, but relative, let's say non-focal aura, just aura less than 1 hour, not severe aura, that means they can relatively take COCP. So something to focus on. Diabetes is a relative contraindication. SLE, controlled blood pressure. Uncontrolled is an absolute contraindication, but controlled hypertension is a relative contraindication. Hyperlipidemia. There was an hyperlipidemia up there, which was triglyceridemia, which is congenital, so contraindicated absolutely. But relative is hyperlipidemia, sickle cell anemia, gallbladder disease. Drug interaction risk: rifampicin, phenobarbital, phenytoin, griseofulvin, primidone, St. John wort can decrease efficacy of CHC contraception, requiring the use of backup method. Let's say a patient is on either one of them, so make sure we are advising them to use a backup contraceptive method, because these medications can reduce the effectiveness of COCPs. No evidence of fetal abnormalities if conceived on OCPs. No evidence of that OCP is harmful to nursing, in fact, but may decrease milk production. So OCPs are not harmful for nursing infant, but they can reduce milk production because of the hormonal effects. And let's say this could be one of the NAC OSCE station case as well, or QE1 question as well. That let's say if a patient has conceived on COCP, she's coming in now, she's really worried on what to do. So there is no evidence of fetal abnormalities if conceived on OCP. Okay, so that's something reassuring for any patient who's coming into your clinic or during your exams. Now, selected examples of OCP. So the most common ones, I've seen Elise, I've seen Yasmin, I've seen Yaz. Tricycline is another one that I've seen. So these the active compounds in these ones are estradiol and progesterone combination, but the amount of different kind of different kind of hormones is different. So Elise has 20 picogram of ethinyl estradiol and levonorgestrel 0.5, whereas 35 when tricycline along with triphasic oral contraception, graduated levels of progesterone. Yasmin has got 30 picogram of estradiol and 3 milligram of drospirenone, a new progesterone. So Yasmin is another good one, which is helpful for acne as well, because it has got a good amount of progesterone in it. Along with that, Yaz is another one. Yaz has got 4 days of pill free, like sugar coated pills, which gives the withdrawal bleeding. So that means 4 days means less withdrawal bleeding. Drospirenone has anti-mineralocorticoid activity and anti-androgenic effects. So drospirenone is another one. So let's say in an exam they may ask you questions like, let's say a patient is coming in for contraception and she prefers having an effect on her acne as well, something that is better for her acne. So you can pick Yasmin, Yaz, or drospirenone, which is another anti-mineralocorticoid or anti-androgenic effective OCP. Okay. Advantages. So advantages: low dose 20 picogram OCPs, less estrogen side effects in Elise. So low dose of estrogen Elise. Tricycline has low androgenic activity, can help with acne. So tricycline is another one which is helpful in acne as well. Yasmin and Yaz decrease perception of cyclical weight gain, bloating, fewer PMS, improved acne. So improved acne is with two, tricycline and Yasmin. Good reminder to mark it as a QE1 question, because tricycline, Yasmin, Yaz are good for acne. Yasmin and Yaz are good for PMS symptoms and weight gain and bloating. So depending on the concentration of estrogen and progesterone, that's how you need to decide on which medications are you going to prescribe or suggest to your patient. Now, what are the disadvantages of using Elise? So Elise low dose pills can often result in breakthrough bleeding. If this persists for longer than 3 months, patient should be switched to an OCP with higher estrogen content. So this one has a low dose estrogen. So if patient is consistently having breakthrough bleeding, her cycles are not regular within 3 months, she can then switch to another higher estrogen content OCP. Tricycline, the only thing is, unlike monophasic OCP, triphasic OCPs cannot be used for continuous menstrual suppression. Yasmin or Yes has a risk of hyperkalemia, rare contraindicated adrenal insufficiency. Check potassium if patient also on ACE inhibitor, ARBs, potassium sparing diuretics, or heparin. So that means Yasmin and Yas has drug interaction with ACE, ARBs, spironolactones, and heparin, whereas tricycline has a triphasic effect, so cannot be used for continuous menstrual suppression, whereas Elise has a low estrogen component, so patient can still bleed and have persistent breakthrough bleeding. So that's that. Now on the right side, there's a table about missed combined OCPs. Miss one pill in less than 24 hours, take one pill ASAP, and then a next pill at the usual time. Let's say they've just missed one. Very relevant for QE1 and NAC OSCE for sure. One pill missed, that means you'll take your next pill, you'll take your missed pill right away, and then you'll take your next pill at the usual time. More than two pills in a row in the first week, so take first pill ASAP and continue taking one pill daily until the end of pack. Use backup contraception. 7-day emergency may be necessary. So let's say if you miss more than one pill in a week's time, that means now is the time that you have to have emergency contraception as well, and then backup contraception as well. Less than three pills missed in the second, third week of the cycle, take one pill ASAP and continue taking one pill daily until the end of pack. Do not take placebo. Do not take the hormone-free interval. 20 days. So you can continue taking. Let's say if you missed three pills in second, third, and fourth week, you have to continue taking one pill daily until the end of pack, and you don't have to take the breakthrough bleeding ones, the sugar pills. Start the next pack immediately after finishing the previous one. No need for backup contraception. So you don't have to have the backup contraception. But let's say if you've missed multiple pills, less than three pills, then you have to continue taking your pills without taking the sugar pills or the breakthrough bleeding one, the brown ones that I showed you initially. So let's say if you missed more than three pills, take one pill ASAP and continue taking one pill daily until the end of pack. Do not take placebo 28 day pack, or do not take the hormone free interval. Start the next pack immediately after finishing the previous one. Use the backup contraception for 7 days. Emergency may be required. So if more than three pills are missed, you continue taking the hormonal ones only, no sugar pills, until the end of the second pills. And also make sure you use 7 day of backup contraception as well, and also have the emergency pill ready, like the plan B one. Now, progesterone only method. Progesterone only pills are basically progesterone only pills taken daily with no pill free interval. Advantages: patient control, does not impact breast milk supply. So, the progesterone only pills are the ones that are usually prescribed in postpartum females who are breastfeeding or lactating their kids, and they want to have contraception. So, these are the ones that we usually provide. The disadvantages with this one is must take an exactly the same time every day, so compliance can be challenging. The other one is intrauterine system, small devices left inside the uterus for a maximum of 5 years. Mirena intrauterine has better for women with heavy painful periods, 20% amenorrhea rate. Kylina is another one, best for people who want light period every month or are mainly looking for birth control. So Kylina gives periods. Mirena has no decreases the painful periods. Advantages: convenient, low hormone dose, minimal side effects, no side effects on breast milk, quick return of fertility once removed. Disadvantages: uncomfortable, too potent, very, very painful, must be inserted and removed by a doctor, really can have uterine perforation or intrauterine expulsion. So infection, bleeding, expulsion, uterine perforation, these are the disadvantages. But advantages is that it has low hormones, it is effective, and it has got no side effects on the breast milk. Very effective reversible contraception, more likely to be an ectopic pregnancy if conception occurs, lower absolute risk of ectopic compared to other contraceptive methods. So intrauterine system is good for 5 years, and now I've heard like it is good for 5 to 7 years, even like 8 years. So that's that. And Depo-Provera is an injectable medroxyprogesterone 150 milligram injection every 12 weeks, every 3 months. Suppresses ovulation, complete amenorrhea in 70% women after 1 to 2 years of use. Does not affect breast milk, effective for dysmenorrhea as well. Disadvantages: breakthrough bleeding, weight gain, decreased bone density, may be reversible. Restoration of fertility may take up to 1 to 2 years. So with injections, the problem is the patient may not get periods for 1 to 2 years, but then they're not sure about the return of fertility as well within 1 or 2 years. So that's the problem. Otherwise, that is injectable every 12 weeks. That's that. Nexplanon is 4 centimeter long, 20 milligram etinogestrel implant that is placed in the inner arm and lasts for approximate maximum of 3 years. So that's basically a device that is inserted in subdermally into your skin, and it lasts for 3 years. Advantages: it does not affect the breast milk, do not have to put something in the uterus, good bleeding and pain control, no changes in bone density, quick return of fertility once removed. Disadvantages: breakthrough bleeding and weight gain with Nexplanon. So Nexplanon is another one, Depo-Provera injection, IUD, intrauterine system, progesterone only ones, and progesterone only pills. So these are these, and now we're going to talk about progesterone only contraceptive methods. So what are the indication? Does not affect breast milk supply, which is very appropriate for postpartum women. Women with contraindications to combine OCPs, let's say someone is having thromboembolic condition, myocardial diseases. Women intolerance of estrogenic side effects of combined OCPs can be, this is a good indication for them to use progesterone only contraceptive methods. Mechanism: progesterone prevents LH surge, thickening of cervical mucosa, decreased tubal motility, endometrial deserialization, ovulation suppression. Oral progesterone do not consistently suppress ovulation compared to combined. Side effects may be irregular menstrual bleeding, weight gain, headache, breast tenderness, mood changes, functional ovarian cyst, acne, oily skin, and hirsutism. Absolute contraindications for progesterone only contraception is current breast cancer, known suspected pregnancy, undiagnosed vaginal bleeding, benign malignant tumors, liver tumors, severe cirrhosis or acute liver problems, breast cancer, pregnancies. These are all contraindications. Now the boxes on the right side says irregular breakthrough bleeding often occurs in the first few months after starting OCPs, obviously because it's hormonal, usually resolves after 3 cycles. So 3 months follow-up is scheduled because after 3 months this usually resolves. Progesterone only contraception must be taken at the same time every day. So progesterone only should be taken every same time every day. One thing to remember about progesterone only is like very good for patients who are in their postpartum phase, who are lactating, because it does not affect the breast milk production, whereas estrogen does. Okay, continuous or extended cyclical versus cyclical use of COCPs for contraception. Conclusion is this recently published updated systemic review identified further for RCTs, however result did not change. Okay, nothing significant on that. Now coming to IUD, intrauterine devices. Intrauterine contraceptive methods are two different that we discussed: copper IUD and the hormonal ones. Copper one contains mild foreign body reaction in endometrium, toxic to sperms and alter sperm motility. What is the benefit of using copper one is like it's non-hormonal. Return to baseline fertility after removal is very fast. No estrogen, does not affect breastfeeding, can use if smoker, hypertension, previous venous thromboembolism. So bleeding condition, smoker, any kind of other high blood pressure related problem, they can use copper IUD. Insertion is uncomfortable, must be inserted or removed by doctor. Infection is another one, especially if multiple partners within first 10 days of insertion. And then uterine wall perforation, both it's for both hormonal and non-hormonal. 1 in 1 lakh uterine perforation, that means very low risk. Expulsion 5% in the first year, greatest in the first month. Chance of pregnancy very low, but if pregnant higher relative risk of ectopic pregnancy or miscarriage. IUS, intrauterine system, do not protect against STI. Side effects of copper one is increased blood loss and duration of menses. So usually the copper ones usually increase the blood loss and duration of menses, dysmenorrhea, increased vaginal discharge. An absolute contraindication to copper one is both copper and progesterone IUS known for suspected pregnancy. If there's suspected pregnancy, you're not supposed to use copper one. Undiagnosed genital tract bleeding, acute chronic PID, lifestyle risk of STI, known distorted uterine cavity, immediate post-septic abortion, or known allergies to copper or Wilson disease is a contraindication for copper IUS. Now we're talking about Mirena, Kylina, which are the progesterone-related intrauterine system, which thickens the cervical mucosa and minimal effect on ovulation and deserialization of endometrium. So these are basically, these last for 5 years and can be removed before that if desired, can insert immediately after placental delivery and post-abortion. I've seen patients who right away get their IUDs in after they deliver a baby, and even after post-abortion they can get it. The risk of all IUS is similar, the benefits is similar, the side effects profile is different for, let's say, progesterone intrauterine system: spotting, bloating, headache, acne, breast tenderness, nausea, headache, ovarian cyst formation, vaginal discharge, or mood changes. Why? Because it's a hormone. And then the relative contraindications to copper or progesterone is valvular heart disease, past medical history, PID, ectopic pregnancy, presence of prosthesis, Abnormal uterine cavity, intrafibroid, cervical stenosis, immunosuppression, abnormality of uterine cavity, copper IUS, severe dysmenorrhea, heavy bleeding. So copper IUS may copper IUS is contraindicated in severe dysmenorrhea, heavy menstrual bleeding. Why? Because IUD can cause increased blood loss generally. Cervical swab for chlamydia and gonorrhea should be done prior to insertion. Now we're talking about emergency contraception, which would then complete, the objective for contraception. So now we're talking about emergency ones, which we've already spoken about in family medicine chapter. Now this section is from gynecology, so we'll then be finished with contraception. Hormonal emergency contraception and non-hormonal ones. So the hormonal ones, as we've spoken about before as well, use plan B, USP, two tablets, then repeat 12 hours. So you have to take two tablets repeat over 12 hours. Can substitute with any OCP as long as it contains 100 picogram of ethinyl estradiol. So you have to provide the patient with 100% of ethinyl estradiol. 2% overall risk of pregnancy use within 72 hours of unprotected intercourse, limited evidence of benefit up to 5 days. Which one was the benefit one? It was the copper IUD one that we discussed before, that it's going to be effective within 5 days. But these plan Bs and hormonal ones are effective within 72 to 24 hours. Efficacy decreases with time, less effective at 72 than 24 hours. Mechanism of action, unknown theories included suppression ovulation or cause deficient luteal phase, alters endometrial to prevent implantation. Affects sperm over transport. Nausea would be another side effects that due to estrogen patient may get, that can be treated with gravel and irregular spotting. Contraindication pre-existing pregnancy, although not teratogenic. Caution in women with contraindications to OCP, although no absolute contraindication. Plan B, used within 72 hours of unprotected intercourse, can use up to 5 days. And this one has got 750 picogram of levonorgestrel. Every 12 hours, 2 doses, can take 2 doses together. Greater efficacy 75 to 95 if used within 24 hours, and better side effects profile than USP. So plan B is better than USP, and this has to be taken within 24 to 72 hours. The earlier it is taken, the better it is. No estrogen, there's fewer contraindication side effects. Less effective if more than 75 kgs, not recommended in more than 80 kgs. So if, let's say, if there's an obese patient, so plan B is not as effective as compared to other emergency contraceptive methods. Same as above, no caution in women with contraindications to OCP. So let's say a patient has a contraindications to OCP use. So there's no problem. They can use Plan B, considering that they should be less than 75 to 80 kilograms. 2 pills taken within 24 to 72 hours. Okay. Ulipristal is a 30 milligram per oral within 5 days of unprotected intercourse. Selective progesterone receptor modulator with primary anti-progesterone activity, may delay ovulation for up to 5 days. Headache, hot flashes, constipation, endometrial thickening, same as above. So ulipristal is another one. Non-hormonal ones are copper IUD, inserted within 7 days post-coital, prevents implantation. 1% failure rate, can use for short duration if high risk for individuals. Follow-up is 3 to 4 weeks post-treatment to confirm efficacy and confirmed by spontaneous menses or pregnancy tests. So let's say if you have done emergency contraception for a patient, now after 3 to 4 weeks, if there's no menstrual cycle, they need to repeat their pregnancy test, and contraception counseling should be done. Let's say if patient had an abortion. Recently I had a patient who had an abortion, so for me the talk was not just limited to abortion itself, but it was more about contraception, the methods of contraception effective for her, and then we did a referral to the gynecologist who can do contraceptive IUD for her. So, in general, honestly, everything that we're studying here is very relevant to clinical practice as well. So make sure anything that I've mentioned here in terms of QE1 and NAC OSCE, you focus on that. For NAC OSCE, make sure you know the duration of each method, which one is more effective, and what are the contraindications, what are the estrogen related complications or side effects, or progesterone related ones, which is more preferred for pregnant postpartum female who's lactating. And then what are the relative contraindications or absolute contraindications, like cardiac conditions, bleeding disorders, and all that, because these are the things that I am actually clinically practicing now. So now I know like why are these things important which we reads in book, because patients do have questions on the similar thing. Like missing pill is another hot topic that patient can come in the clinic, and you can even get a NAC OSCE case on that. So I hope this video was helpful. Comment down below if there's any specific topic you want me to review, so we can, review that topic together. I can tell you what's important for QE1, what's important for NAC OSCE, and then what is clinically relevant. And then with these videos, I think I can share my residency experience with you guys as well. So that should be also helpful in general. Yeah, I hope you like the video. Make sure you subscribe to my channel, and also like this video, and comment down below if you want me to review any specific topic. And good luck with your preparation.